I think this is probably the most important first step really, is I find picking the appropriate person, and that's often determined by what medications they're taking, but also very importantly what the individual's sort of goals and aspirations are, and trying to work out what are their personal preferences, what are their personal goals, what do they see as the result that they may get from taking this medication that you're perhaps envisaging stopping. And often their goals may be very different from yours, and somebody's reason why they're taking a blood thinner may be because they're very concerned that they don't want to go the same way as Auntie Maud and have a big stroke, whereas they may not be quite so worried about the bleeding risks from the medication, whereas you may feel slightly different as a doctor. But it's really important to make sure that the person you're dealing with is agreeing with what you're proposing, and taking into account their personal preferences is actually a very important part of the process. And unless you can take the person with you, you're in strife.
Yeah, often the family also has a big role. You know, they often want mum to live forever, and they believe the medications are contributing to that, when in fact sometimes it's can be the other way around.
Sometimes we do our job a little too well, don't we? You must take your statin because that's really important. We really drive home compliance, but almost to the detriment of having good, honest conversations about withdrawing medications.
It's that you must take this for the rest of your life thing again, isn't it? Yeah.
And I think the other thing that's important is to try and understand your patient better, not entirely just in their preferences, but also trying to work out, are there other factors in them which make a particular drug more dangerous than any other? And I think probably the big one really in an older population is frailty. And we know that it's an independent risk factor for bad outcomes with any sort of medical intervention really. And so we need to probably try harder to try and identify that. And there are various sort of clinical markers of frailty, associated with confusion, malnutrition, poor social circumstances, etc. And there are very easy sort of bedside tests you can do. So gait velocity is a very important predictor of frailty. So if it takes you more than 5 seconds to walk 4 metres, then you're probably in the frail group. And also often just the eyeball test is really important, just looking at somebody and thinking, are you somebody who's a robust 80-year-old? Are you really a sort of 90-year-old biologically in an 80-year-old chronological body? And these are the sort of, value judgments that we make every day, but we probably need to think very carefully about with deprescribing.
Yeah. I think GPs are really well placed to be able to do that also, because frailty over time can be compared as well. I sometimes see somebody and think, goodness, you've lost some weight, you look so much less well and more fragile since last time I saw you. And also asking the family about that as well. They often are really good key historians, and being able to tell you what mum used to be able to do even 2 years ago compared to what mum can do now.
And often it's the interstate family that visits once a year that notices the big steps, shift. Whereas the the local family, it just creeps up on them. I've noticed that with my own family, people visit and you go, there's a big step down.
The other aspect of looking at the patient and trying to assess them is often working out, once you've decided what their goals are, and elderly frail patients by and large are much more interested in quality of life rather than length of life, but to form some sort of guesstimate of perhaps their life expectancy, and that's particularly relevant when you might be giving people preventative drugs, so statins to prevent them having a heart attack or antiplatelets to prevent them having a stroke. Because if their life expectancy is very short because of other intercurrent illnesses, cancer, severe heart failure, etc., then your preventative drug's not necessarily going to deliver the goods. So these are the important aspects I feel that we need to look at when you're looking at the individual person. And life expectancy itself often your eyeball assessment, would I be surprised if this person died in the next 6 to 12 months, is just as reliable as any actuarial table that you might be able to pull off the internet. And I guess the person-centred approach to medicine is really just as important with deprescribing as it is if you're prescribing a new medication or proposing a new form of treatment, because the patient needs to be engaged in that process. Their carers and their relatives need to understand why you're doing it and what the likely outcomes are to be for it to be successful. So,
and many of the medications, they take 3 to 5 years to have any benefit. So, if your life expectancy is well below that, then it really does make it futile. Yeah.